When we talk about rehabilitation after an anterior cruciate ligament injury or surgery, we usually think of the quadriceps, hamstrings, or gastrocnemius muscles. That's the usual thing, but there's a muscle that determines the biomechanics of the knee with every landing, and which often isn't measured objectively, the gluteus medius. And when the gluteus medius doesn't respond properly, the knee suffers for it. This muscle plays a key role in pelvic stability, in controlling adduction and rotation of the femur, and in resisting dynamic knee valgus. When it fails, one of the patterns most closely linked to ACL injury and relapse can appear: hip adduction combined with knee valgus right at the moment of impact. The problem is that this pattern occurs within milliseconds and is not always detectable to the naked eye. A patient may appear stable, have good strength in an isometric test, and even perform controlled exercises well, yet still display a reactive deficit at the actual moment of landing. In a study that evaluated muscle activation during a single leg drop landing, patients with reconstructed ACLs were compared to healthy subjects. EMG was used to measure the activation of the gluteus medius, the activation of the adductor longus, the coactivation ratio between both muscles, and the reactive response in the first millisecond after ground contact. The results revealed two important findings. The first was that in patients with reconstructed ACLs, the peak activity of the gluteus medius after contact was lower than in healthy subjects. This is not just about maximum strength, but about the muscle's ability to respond at the critical moment of landing. If the gluteus medius is less active at that moment, its ability to control adduction and internal rotation of the femur is also reduced, which can increase knee valgus and the load on the ACL. The second finding was that the synergy between the gluteus medius and the adductor longus was altered. Patients with a reconstructed ACL showed a lower GMED to AL ratio than healthy subjects. This ratio is interpreted by dividing the activation of the gluteus medius by the activation of the adductor longus. When the ratio is less than 1, it means that the adductor longus is more active than the gluteus medius during landing. In other words, the muscle that promotes medial collapse dominates over the muscle that should help to prevent it. In practice, this can result in a dynamic valgus pattern. The adductors organize the movement and the gluteus medius does not generate a sufficient response to compensate for it. Why does this happen? It's not just due to a lack of strength. Inhibition of the gluteus medius after injury or surgery, disuse, reduced central drive, changes in motor control, and compensatory strategies that the patient learns to protect the injured knee can also play a part. The problem is that these strategies do not always disappear once the structure has recovered. That's why in ACL rehabilitation, it's not enough just to measure strength. We should also assess how the neuromuscular system responds during dynamic tasks. There are 5 particularly useful parameters during jumps and landings: the reactive activation of the gluteus medius in the first milliseconds after contact, the ratio between the gluteus medius and the adductor longus, femoral control in the frontal plane, pelvic stability in the first 200 or 300 milliseconds, and lumbopelvic compensations that appear when the gluteus medius does not respond as it should. This assessment can be carried out from the moment the patient is able to perform a single leg landing safely, usually in the middle or later stages of rehabilitation. And it is important to understand that a patient may have good gluteus medius strength and still present a reactive deficit, because strength under controlled conditions does not guarantee an adequate response in dynamic situations. These are different abilities and should be assessed differently. How is this reactive response trained? With exercises that replicate the real demand, single leg landings, changes of direction, plyometric tasks, and exercises with visual, tactile, or electromyographic feedback. Real-time EMG allows you to check whether the muscle responds at the right moment and with the appropriate intensity, and to adjust the exercise based on that information. That is why ACL rehabilitation does not end when the quadriceps regains strength. It ends when the neuromuscular system is once again able to organize movements safely in high-demand situations, such as landing from a jump. The gluteus medius and its relationship with the adductor longus are 2 very relevant variables in this process, but they are still rarely measured in routine clinical practice. Not because they are unimportant, but because without EMG they're almost invisible. Measuring the reactive activation of the gluteus medius, the GMED ratio, adductor longus and pelvic stability after contact gives you a picture of motor control that a strength test alone can't provide. And that picture can help you decide whether your patient is truly ready to return to spool, or if the pattern that put them at risk the first time is still present. Do you want to learn how to use EMG to assess the synergy between gluteus medius and adductor longus in patients with ACL injuries and make discharge decisions based on real data? Request information and discover how to apply it in your clinical practice.